Good morning, everyone. I'm Dr. Louie Fouche, and I'm intensivist in Marseille. I should speak in French normally, but I think maybe our French translator has COVID, so I'm going to try in English, and you may forgive my accent and my poor English if I mess up. So I work in Marseille, and I'm speaking for myself, and also I'm contributing to the Independent Scientific Council, and I work on this presentation with the independent scientists of Reinfo COVID, which is a group that we created, which is free from any conflict of interest. And that's the case for myself. I have 57 euros notified on Transparence Santé, which is the transparency database registering the conflict of interest in France with drug industry, vaccine industry. I don't have any stock option in any numeric firm or assurential prudential company. And I speak under the law of the 4th of March in France, which pushes us to give a clear, loyal, and information grounded on clean science and on clinical experience and also common sense. And you know, I'm sued in France for what I'm going to tell you. So I just recall that law. It's important. It's also in the deontologic code, medical code. So I'm going to deal with masks and lockdown again. You already told a little bit about that, but trying to keep a cool temper over those political decisions and what we call non-pharmaceutical intervention that have been done. It's my job to keep calm when everything is going wrong, and so we're going to try to do that. Slide, please. And we're going to try and weigh the benefit and the risk, because any sanitary or medical decision should weigh the risk and the benefit and then take a decision under the uncertainty. And you're always under uncertainty, but you have to make a decision, bearing the consequences. And that's what we call consequential ethical. One of the points to keep a clear mind is to have an historical context which is clear, and to also avoid being blurred and disorientated in space and time. So I just recall a few historical landmark and plots. In 2020 in France, we identified in January this novel coronavirus, and then between March and May, we had the first lockdown for 55 days, and it was compulsory for us to fill in an auto-attestation to have the right to go out. You know, we were giving ourselves an attestation to have the right to go out. And the mask got mandated in public transportation in May 2020. And then in July 2020, the mask was mandated in enclosed spaces and public places at the same time. And during the time of the summer, in August, the mask wearing was mandated in the streets of any city. And then in September, the mask was mandated in workplace and also in schools. And then in November, for children after 5 years old in any school. And we got a second lockdown for 45 days between October and the end of October and December 2020. And then another lockdown in 2021 between April and May for 1 month. Slide, please. How can we make a decision over this point of the mask? We have the institutional position that were up to date before, and so before 2020, there was no doubt for the WHO that the mask in general population was of no utility. You have about 120 different trials showing that there's no utility at all. And it was also questioned in the surgery room, you know. So if it's not sure if it's efficient in a surgery room, it's surely not in the street for a general population. Next slide, please. You have another source of information. You have institution, you have the past science, but you have also what the firm and the manufacturer of the pattern are saying. And all the manufacturers of masks and surgical masks noted on the boxes of the mask that it was not providing any protection against coronavirus. So this is just a big point. If you don't follow what the manufacturers say, this is kind of insanity. Next slide, please. There was an interesting study in the British Medical Journal in 2002, secondarily to a Red Cross work in Guantanamo, showing that the prisoner treatment was bordering torture. And I gave you a picture of those prisoners. They have masks. They have masks and they are insulated. They have sensorial privation. It became the normality in 2020 for the COVID pandemic, and the new normality for children in Thailand who were insulated in the school, just like you can see. And this psychological treatment has big sequela. We can see there in the Spanish translator that they're traumatized and they're still wearing a mask in 2023, which is no sense. Next slide, please. Michael Ryan, who is the team leader for the containment of the epidemic, stated that there was no evidence to suggest that the wearing of masks in the entire population was beneficial in any way. And he said that in March 2020. And in fact, he said, and I quote, "There is some evidence to the contrary. And due to the improper wearing of the mask and you touching everywhere and giving and transmitting the epidemic and the contagion by the manuportage. In April 2020, there was no evidence neither that the use of the mask by healthy people in public spaces, even generals, could prevent any respiratory virus, including the coronavirus. Today, the masks are recommended following a recent exposure to COVID-19, or for somebody who if you had contact with somebody suspect of COVID-19. And still, when you go in the metro or in the train in France or in Belgium, you are recommended to wear a mask. We're going to see if there is science about that. Next slide, please. The European CDC in February 2020 said a conclusion. There is the evidence for effectiveness of non-medical intervention and medical mask wearing by the general public is non-existent or very weak. The Norwegian Institute of Public Health said at the same time that there's no evidence that medical and non-medical masks are effective in preventing transmission in the general population. They compute and calculate how many persons should wear a mask to prevent from one infection. And they compute that they needed 200,000 people who would need to wear a mask to prevent one single new infection per week. The number to treat is just insane. Next slide, please. We have science about that, and there's a big meta-analysis made by the Cochrane Library, and which is usually cited by Jefferson and Alter, which got interested into the physical intervention to interrupt or reduce the spread of the respiratory virus. And it first got interested into the medical and surgical mask, and comparing to no mask. And about 18 randomized controlled trials have been pulled, and they said there was no effect, no relative effect. It was not significant. So there's no effect of surgical mask on preventing respiratory illness. Next slide, please. They got interested into comparing the N95 or FFP2 respirator, which has the duck masks that you can see. They pulled 13 or 14 RCT, randomized controlled trial, and no relative effect was shown on that. No difference between respirators and the other mask or no mask. Next slide, please. So they conclude that the mask would be a symbol for the society. Maybe you're protected and you think so, but the evidence says you may not be. Thank you. Next slide. There was an interesting study called Denmark, and that you may have heard about, which took place in Danish and in Denmark, and it was a randomized controlled trial enrolling 6,000 adults in two groups, mask or no mask, and the primary outcome would be the SARS-CoV-2 infection and what months by PCR or antibody testing or an hospital diagnosis. And the result was there was 1.8% of infection and then 2.1% of infection between mask wearer and non-mask wearer. So there was no statistical significant evidence that mask wearing should prevent from SARS-CoV-2 infection. That's the major impact in science. Thank you. Next slide. I must cite the opposite, you know, otherwise I would be taxed of cherry picking. And there was a study made in Bangladesh, and which is usually cited by the governments and the media as a proof of the mask utility, and which showed that there would be a relative efficiency of 11% reduction between the people who wear the mask and the people who don't on the COVID symptoms. That's the boxes you can see on the left, and on the symptomatic seropositivity, relative efficacy of 9%. What is it? Relative efficacy? Because this is kind of a trick, a trap. You must count, if you have 2% infected over 100 and you got to 1 over 100 in the other group, you have 50% relative efficacy. But absolute efficacy would be 1%. Okay? So what is the absolute efficacy in those groups? The absolute efficacy is that you need 104% to spare one COVID symptom. And in the second main point, which is symptomatic seropositivity, you would need to mask 1,200% to avoid one COVID seropositivity. So this is what concludes the science when it's on the opposite. Thank you. Next slide. There was a nearly experimental nested study in a court in Catalonia in Spain, because they did some test and PCR in every single child they found between 3 and 11 attending school. So it was nearly a experimental study, you know, and it was 600,000 children that were tested like that. So that's a big cohort. And between mask and non-mask, the attack rate of the infection was 4.3% and 4.6%. There was no difference, concluding that the mask mandate in school was perfectly ineffective. Thank you. You can come to the next slide. So that's about the children, because it was a big subject and it made a lot of us react when they masked the children. Even our dear Anthony Fouche concluded like 2 weeks ago in the end of April that from a broad public health standpoint at the population level, masks work at the margin, maybe 10%. Even him says that. You can switch to next slide, please. So there's also some risk, you know, and the risks are important. You have several studies trying to find if the capnid, meaning the CO2 in the blood, is increasing when you're under the mask, and it does, 7.4% of increase in 2 studies in medium. And so this has been reported by the WHO. Okay, I'm getting to the end. Thank you. Can you pass to next? There are also graphene-contaminated masks, and the ANSES, which is our national agency for security of the different medication, said that, and even a very single intratracheal installation in mask, it persists for 28 days, and it goes in liver and spleen, meaning that it goes through the bloodstream. So it shouldn't be there, but it has been distributed to the healthcare workers, though. You can pass. Okay, you can pass, thank you, but we can find some fungi in the different masks when it's used, and so you can auto-contaminate yourself with that. This is about lockdown. I'm just going to tell you something that maybe interests you. We use usually an epidemiologic model called SIR, meaning that you have susceptible people of infection, and then infected people, and then recovered people. And we got 2 different diffusion parameter called beta and gamma. And beta over gamma is called R0 that you heard about so many times. And beta is the diffusion rate, meaning the speed of diffusion of the infection. And we compared the beta between different countries. We modelized that. You can go to the next one, in Europe. And you can see that these are the curves of the infection for COVID mortality with our world in data. And we fit that model over the curve that we have, and it was perfectly fitting, you know. So the prediction, the mathematical prediction, is perfect. And we compare the beta between the different groups and the different countries. You can get to the other one. It was around 0.25. Thank you. You can switch slide, please. It was 0.25 in nearly every country except one, Sweden. Guess why? Guess why? Very homogeneous. So the mathematics proves that the lockdown have increased the speed of virus diffusion by 50% compared to the Sweden. It was faster when you locked down. We're getting to the end. Thank you. I'm concluding. Can you get to the end? But there was a lot of evidence for secondary effect of the lockdown also. It's been raised in a very good article by Ioannidis about mass formation into the population, the drift toward inequalities and harsh inequalities, socially, economically, and sanitarily speaking. So, as a conclusion, in 2020, there was no evidence of benefits of mask wearing in general population. In 2023, that's the same. There's still no evidence of benefits after 3 years of mask mandates, and there is a significant risk for children in wearing this mask. The lockdowns is a failure in slowing the epidemic spread, and the mathematics is showing it. The lockdown bear major risk for social and societal inequalities and mass formation risk. So finally, you can conclude, and we make a consensus conference over that and say, great A for everything. Lockdown must be avoided. Mask mandate in general population and children must be avoided. Thank you.